Vanessa Moss Award is usually given to the research which are done on the cancer care disparities, and it is given during the London Global Cancer Week. Each year they conduct this program, and they identify the people who are doing work on the cancer care disparities. So this time we presented our data on the BC-RADS 2 study, which stands for Breast Clinical Reporting and Data System 2. So we all are aware of BI-RADS, that is BI-RADS, that is Breast Imaging Reporting and Data System. So we have come up with a clinical version of that, and that study got the Vanessa Moss Award out of around 65 to 80 clinical trials and different other presentations which were submitted to London Global Cancer Week. So it's indeed a matter of pride for us who belong to a low middle income country like India. If we look at the background of this particular study, we need to understand the natural history of breast cancer a little bit. So once a individual gets exposed to certain risk factors, then the patient develops one small cancer. Initially, one cell grows, then it rapidly proliferates into multiple cells. Now, to get a palpable lump in the breast, we need at least 1 to 2 centimeter lump. Before that, it is not palpable by the hand of the patient or by the hand of the clinician. At this stage, we detect cancer with the help of mammography. But if we look at the low and middle income countries, the median tumor size is 3.5 centimeter. Sometimes we get patients who have a tumor size of more than 5 centimeter. Most of the low and middle income countries, they have a delayed presentation. 70% of our patients, they present either in stage 3 or in stage 4. To solve this situation, if we can bring down the tumor size from 5 centimeter to 3 centimeter to 2 centimeter, then gradually we will be shifting to mammography. At this moment, we don't require installation of multiple mammographies across the country. That is not a cost-effective model. If we can bring down the tumor size to 2 centimeter, and which can be palpated very well by the clinicians. So right now, our focus should be a good clinical palpation, a good clinical breast examination. So our aim of this particular study was to standardize the clinical breast examination, because in our previous study, that was a part of the BC-RAD 1 study, we could see that there is a huge heterogeneity between the clinicians as well as the peripheral practitioners while it comes to a breast lump. As a doctor, I can say this lump is a malignant one. Another colleague of mine, he is saying this is not a malignant one. So there was a heterogeneity. We wanted to standardize the thing. Now, with that background, we started doing this BC-RADS 2 and BC-RADS 1 preceding that study to standardize the clinical examination properly. What we do, once a patient comes to the outpatient department or consults a primary care physician, we have a fixed formula of taking few questions from the history and from the clinical examination, some findings of the clinical examination. In the history, we consider the age, we consider the family history, we consider the genetic predisposition, as well as we consider any prior history of irradiation in the chest wall, especially for Hodgkin's lymphoma in the childhood. These few points in the history and in the clinical examination, we have categorized whether the patient has a breast asymmetry, whether the skin and nipple changes are present, whether the lump is present, and what are the features, clinical features, and whether the lady has any lump in the axilla or not. Based on these, we have used this formulation retrospectively in our thousands of data, and we could come out with these parameters. Now, based on these parameters, we score the breast lump, we score the patient. If the score is more than 7, there is a high likelihood of malignancy being present in the breast lump. So if the patient is having more than 7 score, then it's an alarm for the clinician. Now here we got a objective valuation of the breast lump or the symptoms. And based on the score, we can suggest the next scope of action. If the score is benign, or probably benign, then we follow up these patients. But if the score is high, we go for a biopsy. If the score is very high, then we go for a fast track referral system where biopsy is expedited. In low and middle income countries, most of the cancers are palpable cancer. We have a disease which is either stage 3 or stage 4. So WHO has given a guideline. If we can detect more than of our 60% patients in stage 1 and stage 2, the outcome changes. We know the stage wise outcome and the mortality varies. If I get a patient in stage 1 or stage 2, the chance of cure is pretty high in comparison to a patient who is being diagnosed in stage 3 or stage 4. So the whole idea of BC-RADS study is to diagnose a cancer at an early stage. We did one study to see the delays in the breast cancer diagnosis, right? So the primary delay is when I feel a lump and I go to a doctor. So this window is called primary delay, and this is the patient who is responsible for this. There is a secondary delay where the primary care physician sees the patient and ultimately the diagnosis is done. And this responsibility is not with the patient. This responsibility goes to the primary care physician also. In our study, we could see that the primary delay as well as the secondary delay both are equally responsible for our patients to be diagnosed at a later stage. So what we thought of, we need to develop a objective criteria by which we can bring down the secondary delay to a significant extent. So now with this BC-RADS, the clinician who is seeing the patient for the first time, he has or she has an objective criteria based on which now the diagnosis of breast cancer is not getting delayed. So with this, we can bring the secondary delay to a significant extent. This is applicable for the palpable lumps as well as where I have a dearth of getting the mammographies or ultrasounds done. So the radiological access is an issue. And this simple history and clinical examination can be practiced anywhere without any gadget. So a peripheral doctor who is practicing in a village or in the remote areas can get this BC-RADS score being done after the examination is done, and now he has a definite criteria. Do I need to refer this patient, or do I need to follow up this patient? Do I advise a biopsy or not? So there is a clear cut guideline based on the BC-RADS score, and the doctor feels more comfortable to deal with this kind of patients. I understand the sensitivity is little higher, so there is a chance of getting some false positives. But if we can follow this for a longer period of time, and later on if we can integrate AI along with this, I think the sensitivity and specificity will increase more. That will be our next phase of this program. We are about to decentralize the oncology care, because in this study we have included the physicians, the breast care nurses, as well as the peripheral practitioners, the village practitioners. and we did not see any difference in identifying the lumps correctly. So the clinical examination and the history taking can be jolly well done by the clinicians as well as the nurses. Now, this can help us in task shifting because we know in low and middle income countries there is a dearth of doctors, dearth of trained breast care physicians. So here we can use the breast care nurses, we can use the peripheral practitioners as a primary level of triaging or primary level of screening by the clinical examination. So this study not only helped us to develop a scoring system, but also it has shown that we can task shift, we can use non-doctor fraternity to detect breast cancer at an early stage in an objective way. This BC-RADS, initially when we did the study, it was in the paper format. So it was the doctor had to write in the paper to get a scoring system. Now we have come up with an app which is on the verge of being launched. It will be launched in next 1 or 2 months. Now, if the doctor has this particular app in his either mobile phone or in the electronic data record system, he or she can just calculate it. So this is the steps 2. After this step, we are now actually training our AI model to further improve the sensitivity and specificity of this particular BC-RADS. Once we get a good result out of it, once we train our AI, when we will feel that this integration into the app will help us in increasing the sensitivity and specificity, reducing the false negativity rate and false positivity rate, then we will be doing this integration of AI in our BC-RADS app. So that can actually reduce the human error and can improve the sensitivity and specificity. WHO had the GBCI, that is Global Breast Cancer Initiative, which is a wing of the World Health Organization to deal with the breast cancer scenario in low and middle income countries. They have set up 3 pillars. One pillar is the diagnosis, and two pillars in diagnosis and initiation of treatment. Another one is in the completion of treatment. So the first pillar they have suggested more than 60 KPI, the key performance indices. The first one is more than 60% of their patients should be diagnosed in stage 1 and stage 2, that is early diagnosis. Once the diagnosis is made, the treatment should start within 60 days of the diagnostic initiation. And third part is the treatment completion rate should improve. So BC-RADS, if can be implemented nationwide at the primary care level, we are significantly reducing the secondary delay. Thereby, we are basically supporting the pillar 1 of diagnosing breast cancer at an early stage in stage 1 and stage 2. And number 2, since this is we are not only diagnosing or giving a score, we are also suggesting the next step. That means when to do a biopsy. So this call to action will help us to reduce the treatment initiation time. Once we get the diagnosis quickly, we can start the treatment quickly, because we all know that early diagnosis can only save life if it is followed by early treatment. Most of low and middle income country patients, they have a palpable lump. But there is a subtle difference between the low and middle income countries versus low resource setting. This BC-RADS, although it was started for the low and middle income countries, but this can be applicable to low resource setting of high income countries also. We have seen certain pockets of high income countries where we have low resource setting. So there also the scenario is not different. There also we get patients with fungating mass with stage 3 and stage 4 because of several reasons. Now, we can utilize this BC-RADS for those low resource setting areas of high income countries too. So this is not a problem of low and middle income countries only. This is a problem of HICs also. So together, if we can implement this after doing further multicentric studies and integrating AI into it so that we can improve the precision, this can solve a bigger problem.